All right, moving to our next speaker, Nehal Parikh, with accurate early detection of cerebral palsy using multimodal MRI at term in infants born preterm.
All right, thank you so much. Good afternoon. I'm privileged to be here to present our team's work today on accurate early detection of cerebral palsy. I have no disclosures other than funding from the National Institutes of Health. Cerebral palsy is a movement disorder caused by brain injury or abnormalities during fetal or neonatal brain development. Despite this, early diagnosis is delayed by at least 2 years of age. And this is a significant missed opportunity to enhance neuroplasticity. A recently published popular international guideline recommends the early use of neuroimaging such as MRI or ultrasound at term corrected age, which is usually the due date for these preemies, plus general movements assessment and Hammersmith infant neurological exam, 2 standardized tests to facilitate early diagnosis of CP. Unfortunately, this approach is not sensitive enough or does not have a high enough positive likelihood ratio for individual level prognostication. Moreover, most prior studies have included high-risk populations with high prevalence rates of CP and a minority of patients with mild CP, which is a predominant form of CP that we see in the preterm population. And this leads to a higher sensitivity and specificity for these prognostic tests. So what we need are tests in an unselected group of very preterm infants, those born at 32 weeks or earlier, and especially in a population that includes a sufficient number of mild CP cases. Advanced MRI modalities such as brain morphometry, diffusion MRI, resting state functional MRI have been shown in small pilot studies to be very promising. One such study that we did measured microstructural properties from the corticospinal tract and corpus callosum in 41 extremely low birth weight infants, and we showed a high sensitivity of 80%, a high specificity of 97%, which resulted in an 80% post-test probability of CP individual level diagnosis. Based on studies like this, we really wanted to combine these modalities to see how well they could do in a large cohort study, which has not been done so far. And increasingly, machine learning is utilized, but again, the problem is these samples are small, these preemie babies are hard to come by, and the number of predictors that these modalities generate is very high. So machine learning is ideally suited to answer this or tackle this challenge, and we believe that support vector machine especially is ideally suited for this challenge. With this background, our goal was to enable early accurate prediction of cerebral palsy in very preterm infants by exploiting machine learning and multimodal MRI biomarkers at term-corrected age. So we put together this large regional cohort study called the Cincinnati Infant Neurodevelopment Early Prediction Study, or SYNAPSE, which studied 358 very preterm infants from 5 Southwest Ohio neonatal intensive care units. These babies are now children between ages 5 and 7. And we're fortunate to have funding to continue to follow them longitudinally. Inclusion criteria included any baby that was born at or below 32 weeks, and this was a consecutive enrollment, and we excluded those that had congenital anomalies of the central nervous system or had cyanotic heart disease. We also excluded a small percentage of infants that were unable to give us high-quality data due to motion. Our primary diagnosis was defined as an abnormal standardized neuromotor exam at age 2 using the popular MELT-SON exam, and they also needed to have at least a grade 1 GMFCS or gross motor function classification system level of at least 1. Level 1 was defined as mild CP, level 2 to 5 was defined as moderate to severe CP. MRI was acquired at term-corrected age, so that's between 39 and 44 weeks. All scans were performed on a single scanner, a 3T Philips scanner. The parameters are listed there. The key thing to take away here is that the diffusion MRI scan, even though we acquired multi-band and multi-shell data for this study, we simply used a single shell of B800, 30 directions, because we wanted to translate this work clinically if possible. We used a simple feed, wrap, and bundle approach that my team has used for over 15 years without the use of sedation, and we were successful in about 90% of the scans in acquiring high-quality data. There's a lot packed in here, but due to the time constraints, I just wanted to go over briefly what we did as far as image processing. We took the structural data, the functional data, and processed it using well-established atlases and pipelines developed by the Developing Human Connectome project. This is a project out of UK that has studied now 1,000 preterm infants and thankfully developed these wonderful atlases and pipelines. And so we developed the structural connectome, the functional connectome, using the 81 ROI atlas, and ultimately, we generated about 14,000 predictors for this model. Of course, that's too many for even machine learning, so we used two feature reduction approaches, including graph theory and non-negative matrix factorization, as you see on the bottom right. This led to 24 predictors and an additional 8 predictors from a priori selected clinical and conventional MRI. And we applied these predictors, or I should say we used support vector machine to model these predictors. And rather than splitting up the data, which already with a sample size of 358, although the largest study of its kind, it's still too small to split up. So fortunately, researchers in this field came up with an approach that is recommended using the full data set, using bootstrapping, and there's a feature that allows for optimism correction. This allowed us to use the full data set and predict CP at the age of 2 using SVM. Since I've had to go over this very quickly, for those that want more details, please feel free to stop by at my poster this afternoon, number 1383, and there's also a poster adjacent to it that is predicting cognitive scores at age 3. So what did we find? First, we had 86% of infants that returned at 2 years, so we were able to get a diagnosis of CP or no CP at this age. 34 infants, or 11% of infants develop CP with the GMF-CS level of at least 1. 11 infants, or 3.6%, had moderate to severe CP in this group. And as you can see, there are several factors that were different at baseline for those with CP versus no CP. The variables in blue are the ones that we selected a priori, and many of these variables, including gestational age, sex, bronchopulmonary dysplasia, age at MRI, and brain injury on MRI, were significantly different between groups. But these are, of course, univariate associations. What did we find? Well, first, how well do existing predictors do? As you can see in this table, the third row, clinical plus conventional MRI, at best you get 58% sensitivity and 80% specificity with an area under the receiver operating curve of only 0.69. When you add these standardized motor measures at age 3 months corrected age, the GMA and Hein in the last row, you get very little change, just a slight uptick in sensitivity to 59 and specificity to 83. With a AUC of only 0.71. And this is a model that is currently in clinical use that's been advocated by this international guideline. With the addition of, first, individually, morphometry, structural connectivity, and functional connectivity each, in rows 2, 3, and 4, you can see the sensitivity is much higher than with the current clinical and conventional MRI biomarkers. going from 58% up to 80% for structural connectivity. In the third to last row, you can see clinical plus conventional MRI and structural connectivity from diffusion MRI. You get a 85% sensitivity and 89% specificity, so a significant improvement from our current approach with an AUC of 0.87. And this is for prediction of any CP, which includes about 60% of infants that had only mild CP. The addition of morphometry and functional MRI, the last row you see, is not very different than with the model that just includes structural connectivity. We used a few other machine learning models to ensure that our SVM approach using the Laplacian kernel was the best one. And our goal was to get the model that had the highest sensitivity, and indeed that's what we achieved. The random forest model, in the last row, you can see the specificity is higher and the positive likelihood ratio is higher. So certainly if that was the goal, random forest does a better job. For moderate to severe CP, you can see the results are even stronger. For clinical and conventional MRI, you get about 79% sensitivity and 84% specificity in the top row. The third to last row shows the combined model with just structural connectivity. You get 92% sensitivity and 97% specificity, a positive likelihood ratio of 43. Definitely sufficient to make individual level prediction with better than 80% post-test probability. So what can we conclude? I hope you will agree that the use of machine learning and multimodal MRI biomarkers acquired at term resulted in significantly higher prognostic accuracy than current existing tests. The addition of a simple 6-minute 30-direction diffusion MRI scan at term corrected age can significantly enhance sensitivity and positive likelihood ratio for prediction of cerebral palsy. Our internally validated model was even more accurate for early identification of moderate to severe CP. And ultimately, we believe this model can be immediately translated to enable accurate risk stratification for neuroprotective research studies and also potentially for targeted intensive early intervention clinical therapies. I'll stop there and happy to take any questions. Thank you so much for your attention.
Great talk, thanks. Just debating because there's only time for one question. Was feature reduction done on all the full sample? This will lead to leakage together with the lack of CV, likely overfitting.
Yes, if I understood your question, because we use the full sample, is that the question, will that lead to overfitting? I didn't fully understand.
I guess so. I have
yeah,
same
so,
information you have.
Yeah, let me go back to that slide. So this approach, so I work with a team of machine learning experts as well, and they were very concerned that we were using the full data set for this, and they always split the data not only for test and training, but an external validation group as well. But my contention was that this is statistically a less powerful approach, and if you factor in optimism correction, you can use the full data set as this tripod guideline from Moons et al. Recommends. This has been out now for about 9 years. It was published in 2015 in multiple journals, including Annals of Internal Medicine. And they recommend, you can use, of course, a split approach or a cross-validation, but it's not statistically as powerful as using the full sample with bootstrapping. And so there is data leakage, and the way to correct for that is through this optimism correction. They explicitly state what steps to take to do so. Even the coefficients are shrunk, so there's a shrinkage factor for the coefficients also. So indeed, when you do all of that, so the results I shared with you were optimism corrected.
All right, thank you. Thank you so much.